please.
Yeah, I'm gonna try.
The price, the cost.
First, thank you, and I'm gonna thank you both, you and Fernanda, in the end of my presentation. But to begin with, I would stress pretty much what Jonathan said about the marriage between refractive surgery and cataract surgery. I think the fields are becoming just one, and especially the idea that you need to talk to the patient. Refractive is pretty much used to talk to the patient, and we need to have a chair time, as you said, and cataract is pretty much the same. So the robots are doing the technical job, but they are not good on human job, and we still need to talk to the patient. And following this path, I would add that some rationale regarding monovision or multifocal vision relates to the quantity, the amount, the number of images that you offer to your brain in the end to dealing with. So if you place a multifocal lenses, that's a bifocal, as Jonathan said, lens in one eye, you will end up offering to this retina 2 images, and then you place another bifocal lens in the other eye, so you offer to the other retina another 2 images. Then you have in your brain 4 images, and you need to choose which one of them you're gonna use for see at distance or near, and maybe these neurocompensation, neuroadaptation, these get used to will be a little worse than if you have less images. That is the idea behind the monovision. The mono, someone called it. It's a vision that it's not preferred vision.
Blended.
Alternate vision. The alternate vision, where you offer to the brain 2 images, one distance and one far, or the opposite, and then the brain picks the one he thinks he likes. So there's less images for the brain to decide which one to pick. This is one approach. The other approach is the more images you offer to your brain, the more combinations it may end up picking, and then the patient will get used to that more quickly. It's very hard to read the brain, the other's brain. It's something I like you saying that the good one to prescribe presbyopic lenses, multifocal lenses on spectacles, are one that is already on the presbyopic age. Like if you are over 40, 45, 50, you are a better doctor to prescribe spectacles for presbyopia than if you are 20, 25. Even then, I really think it's an individual matter. It matters too much, and we have a lot to learn about how the brain functions and what the brain sees and what the brains want to see. In refractive, we are pretty much okay on doing monovision because we can revert, we can have it back. In intraocular lenses, it's a little trickier, so you need to have more procedures. And my really fear about that are the patients that didn't get used to that at all. And with multifocal lenses, you cannot do a refractive procedure to get rid of the complaints. And in some cases, you need to take the lenses out of the eye. So that's my concern. But I really think that they are both good. They are acceptable procedures. They are tested. And we really need nowadays to choose the right patients for the right procedure.
Okay, and just one last thing, because you're working also in private and in a public hospital. So what is the difference? How many, let's say, percentage of the multifocal lens that you would implant in a public hospital? Because more or less this is our market here is not as developed as Brazil. There is not so much money. And even in the private market here, people are not willing to pay the 500, 600 euros more for the multifocal. So what is your experience there? What is the percentage of multifocals in your university? Not in private.
it's very hard to touch this issue in an objective way, because I really think that what you believe is what is going to happen. If you think that for the population, the economics, you're going to place a multifocal lens in the patient's eye, and he won't need any glasses anymore. So it's a good it's reasonable in a financial way of thinking. It's okay. It's probably worth to place the lens in a public patient eye. So we have some places where that has been done. So the lenses cost double or triple, but it's worth in a social environment thinking. Private clinic, I think it's absolutely the same. So the patient really doesn't mind too much to pay a little more for something he can touch. And that's some very important issue in all these fields, that is the tangent. How do you say that's something that you take in your hand?
Something concrete.
Concrete. That if you're going to sell or offer something that the patient can have, can take home, can show to the friends, they would tend to value it more than something that he will just say. Well, I had a laser treatment in my eye, the laser removed some tissue, I'm paying for that. Okay, no, I have a lens in my eye, this is the lens case, the lens is very expensive, it's very good, so it tends to have more value for the patient. But anyway, in private patients, I'm really thinking that they are willing to pay more if they will see the benefit. I think the real problem here, or the core issue here, is the benefit. If the patient feels the benefit, and mainly if we feel the benefit on offering that to the patient, there won't be a big problem on selling that, on offering that, or valuing that.
You know, this issue of cost is very important, and well, some papers, but linked to the industry, they usually they evaluate the cost of glasses and without glasses, but I still think it has to be very customized. Usually, you have the very typical patient for multifocal IOLs, which is usually a female that doesn't have very many activities. But we're in a high volume setting over in the not in the university. In the university, we put only for protocols, only for study protocols. But in the private practice, we put quite a few. And one patient is a patient that works in the field with agriculture. She doesn't read very well, but she needs her near vision and she can't take the glass. I mean, she can use it, but it's a real hindrance for her. So she really felt the benefit in that case. So I think the situation has to be analyzed per person and see what the cost impact will be, and of the quality of life, and that will quality of life and quality of vision according to the activity.
Maybe just to see what the situation here, maybe Dr. Delevic, she's a director of one of the very important hospitals, private hospitals here. What is your opinion on that? And maybe Dr. Stojkovic after that, from the university point of view, just to see where we are in all this story. Just.
We don't have experience with toric or multifocal lens in our hospital, but I think that it is important to have that. Some patients like that, some patients need that, and I think that is good.
Mm-hmm. Dr. Stojkovic, what do you think? What is the university point of view?
Well, seemingly toric lenses would come into university hospitals very soon, I think, because they are very safe, and it seems that they are more reproducibly correcting astigmatism than the LRIs.
Absolutely.
So, and they won't be so expensive, so this will come rather soon, I think. And for the multifocals, refractive, diffractive, I'm somewhat reluctant to do that even in the private practice. It's more risky regarding if you do something wrong in the calculation, then it's a disaster. You have to explant it, you have to do some corneal procedures. If you do an ADAPT corneal procedure, then you are getting more higher order aberrations that you can even imagine with multifocals there, and cornea changed also. So to be on the safe side, monofocals are very good, toric lenses are very good, and okay, I did a few diffractive bifocals by Alcon, and they are probably the best compromise between two worlds that I see, monofocals and multifocals today. But it's still a compromise, and you get less contrast sensitivity, and it's long term. I think that this is a sort of a dead end. And on the other hand, the accommodative lenses maybe do not work at all. So.
Not the way we do. Maybe Vesna, you have a experience. They did some implants with the accommodative lens in Zvezdara hospital.
It was in your hospital, actually.
Okay.
So, I personally do not have any experience with it, but it seems that the patients are demanding today, and the new techniques are offering a better choice for them. So we should offer. We should offer something.
Okay. Nicola, please, and then we'll just finish this discussion.
Just a short one. From the point of contact lens practitioner, I'm no surgeon, but I'm really pushing hard to make my patients wear multifocals or any kind of presbyopia correction, and I'm not doing it really good. At least 30% of them would like to correct their presbyopia in any kind of way, but around 3% are using multifocals, which is a very bad result. Just a week ago, we had a chance to hear a cataract surgeon, well-known cataract surgeon, who started implanting crystal lens HD, which is accommodative intraocular lens. And for the first time I heard, at least it was for me, a new theory of accommodation, which actually putting it when someone wants to accommodate for the near vision, the ciliary muscle gets thicker, the vitreous base goes down. I'm looking at Dr. Stojkovic because I know his knowledge is encyclopedic. The vitreous goes down, the central part of vitreous goes front, and if the intraocular lens is implanted, the crystal lens HD, then the central part of the lens actually bulges, actually it becomes more steep, and now that's how it's actually accommodating. In sense of this, what we're talking about presbyopia without any kind of diffractive rings or having multifocal powers on the lens, this makes more natural situation, of course, if it is true. He said that it is true. It is at the beginning of usage, and well, it sounds like, I mean, whatever I tried in my contact lens prankster, whether it's monovision, alternating vision, simultaneous vision, sometimes the mix and match, I really rarely succeed. It's not the question of price, but this has nothing to do with simultaneous vision, this kind of lens. So I'm wondering if this can work, maybe?
The crystalline lens, the HD, has just come out now in Brazil. We're going to start implanting them now in July. But from what I've seen in protocols that were done, studied in the Federal University, you do have that. You have that in the beginning. But what I see in the crystalline lens, and we've worked with previous versions that just didn't accommodate at all, is that they changed the design of the lens in order to increase spherical aberration, to allow for more depth of focus, but not real accommodation. So I don't think it'll work, because the problem there is in the capsular bag. But they do perform changes in the design to allow for some vision. Their objective is to achieve a J3, a J4, which brings down the limitation without halos and glare, theoretically. So I think it might be okay for a certain kind of patient. I still have to see the results, but we had, I think, one of the studies they did in tomography, an anterior segment tomography, tried to evaluate the dislocation of the lens, And after 6 months, it stopped dislocating, although the patient still maintained fairly good depth of focus and near vision, but not J1 at 30 or 35 centimeters.
Even that central part of the lens stops steepening?
That's what came out.
You mentioned dislocation of the lens. You
Yes.
mentioned steepening of the central part.
It's I don't have the design right here, but they even make it. It looks sort of like a nipple, and right in the middle, yeah. And they came out with that version in Brazil. The newer version of the crystallines, they remove that nipple. I think they increase. I don't recall what they changed, but they removed that. They're going to offer both options, one for somebody who wants better vision near and not as bad a vision, not as bad far vision. So I think they're still searching for some kind of near vision, but which isn't the ideal solution. What we really want is a brand new lens, a lens that actually accommodates without, because these are tricks. I mean, we choose the patient because it's not real. It's good vision, but it's not really natural vision. The vision that we have nowadays that we'll tend to lose. Hopefully, in the future, we'll have something more realistic.
Okay, thank you very much. Jonathan, I need to go to the airport, and we can close this first session. We have another half an hour for coffee break, and then coming back with the second part with the refractive surgery. Thank you for your attention for now. Moramo budemo prilično striktni sa vremenom, zato što i Paulo Shor isto ide na aerodrom sada u 15 do 3 ima let, tako da moramo završiti u roku od sat vremena sve i mislim da ćemo imati vremena. Isto tako, možete slobodno biti aktivniji nego malo pre po pitanju dobacivanja i zviždanja i slobodno, nemojte da se ustručavate. Paulo je inače bio moj mentor za postdiplomskim studijama, proveo je godinu dana na MIT-u i ima na najboljem fakultetu, univerzitetu u Latinskoj Americi, Escola Paulista, ima osnovne laboratorije za biotehnologiju i upravo to ono što ja verujem, a to je da treba spojiti high-tech, visoku tehnologiju sa oftalmologijom i napraviti neki praktičan pristup. Tako da tim povodom sam ja isto se ovde aktivirao na Mašinskom fakultetu i pravimo isto tako jednu laboratoriju. Paulo će danas da priča opet sa stanovišta refraktivne hirurgije, šta treba, šta ne treba, šta je dobro, šta je loše. Možete ga ispreskakati, zaustaviti kad god, a ja ću morati da prekinu za tačno sat vremena da bismo ga vratili na aerodrom, da bi ga žena ponovo pustila da dođe ovde. Paulo, please.
I understood something that you said. The part of the tutorial that I was your mentor is exactly the opposite. So Mirko went to Brazil to me, in fact, as a completed student. He brought his thesis already done, and I just need not to spoil it, not to make a mess out of it. So you in fact, is my mentor in a lot of ways, and you should stop telling that I'm your mentor. You know. Okay. Anyway, well, I tried to prepare this presentation much more as a colloquial talk, trying to raise some issues in refractive surgery. And again, speaking after Jonathan is very hard because he's very calm. He speaks a native English. That's not my first language, not even my second language. But try to interrupt me and to ask questions, as many as you have. And I sure will not cover the whole refractive field. And I will try to leave one or two messages to you. And I hope you will get these messages throughout the presentation. Even the presentation having a lot of slides, some jokes, and I hope you will laugh, or at least try to. You do it. But there are really 2 or 3 major points here in refractive that's mostly related to the doctor-patient relationship. So we're going to tell about some refractive pearls. I'm working with ophthalmology for a long time, and either with private patients or university patients. So in fact, refractive surgery is a different field in the ophthalmology, and we were not prepared for that relationship. You see the relationship you have with women. Someone said we are different species. What's happened? Yeah, what's wrong with this very romantic behavior? And I really think that we need to rethink our relationship with the patient, that become a customer, and in fact we are having a relationship with another person. Meaning that in the beginning, whatever we said, and in some fields, and when I mentioned we were not prepared for that, in some fields of the medicine, cardiology, brain surgery, or kidney transplantation, whatever we said is the truth. And if the patient wouldn't do catheterism or a heart replacement or a valve replacement, he will die or suffer a lot. In ophthalmology is not exactly like that. He may choose. And in refractive, he needs to choose. Because it's in fact, we call it an elective procedure, in the sense that he can elect, he can choose to have it or not to have it, or to have another procedure, or to use contact lenses, or to use spectacles, or use nothing. It won't change his eye, it won't change his organic health not having the procedure or using an alternative procedure. So the best patient is also a customer, but probably is a person like us, and the more the patient knows, the better will be for us to relate with him or her. The more the patient reads Google and the Wikipedia, more doubts and more questions they have, we feel more comfortable on that. It's much better to have a patient that already asked all the questions than the patient that didn't ask any question and will start asking questions after the procedure. That's, I think, is the main idea behind all the slides here. Well, it is not as simple, it's not infallible, it's not 100% safe procedure that will lead everybody to a non-myopic or hypermetropic or astigmatism eye. It is indeed a complex procedure, it fails, it's not that safe, and it not leads to zero at all the time. It seems to be, okay, that's standard, I know that. Okay, we know that. But the patients, when they go to a robotized procedure, a procedure that is made out, mostly they think, out of machines, they expect something very, very, very precise. And in Brazil we call it the engineer case. So when you receive a patient that is usually an engineer, so he wants the things to be done as an engineer would do. So they won't build a bridge that may work, may not. There's some risks that the bridge will fall down. Well, they don't accept that. So to have this in mind is very important, again, to talk to the patient. So let's see an example here. We have a patient with a motivation for decreased spectacle dependency. He's using some hyperopia with some astigmatism, with fairly good vision, 32 years, engineer. And his manifest refraction is the first one, the cycloplegic refraction is the other one. So it's +5, -375. The other one +2.5, -175. It's not a very easy case, but it's an okay case. But the patient is an engineer. So it's kind of tricky situation here. You know he will be better, but you know he won't be perfect. You know you will get rid of some astigmatism, like 80% of it, but there will be some residual astigmatism here. And mainly, you know that this hyperopia won't go away completely. There will be some hyperopia, and you don't know how much. and the patient wants to know exactly how much. So this tricky situation is something that, in the end, when one gets more experienced, he gets more comfortable with the situation. In the beginning, it's very hard to tell the patient what really will happen because we don't know. Anyway, this patient had this topography here. Okay, topography showing more astigmatism in the right eye, less astigmatism in the left eye. I won't go into details. Showing that the cornea has a fairly good amount of tissue to be removed. This is the pachymetry, the central pachymetry. Let me see if I can find a mouse here. The central pachymetry in this area, 540, here 545, something like that. It's okay. This is the aberrometry, showing the same. So now no surprises here. Right eye, left eye. You can see here the amount of dioptry. So the device reads at least a very good, it correlates very well with our refraction. And the amount of tissue that will be removed from the cornea is pretty high. So it's 136 in the right eye and 73, that's okay, in the left eye. And we choose to do a PRK with mitomycin in this patient, adding another risk for the patient. That is the haze formation, the scar formation, and the regression of the hyperopia. Why did we do that? Because, in fact, this patient was part of a protocol, but nowadays we are seeing a shift to PRK, at least in America and in Brazil too. Here, Mirko is reluctant on doing that a lot. Mild, okay. But in Brazil, we are doing more and more PRK with mitomycin. And we think, and I'm part of this thinking, that PRK is a pretty safe procedure, safer than LASIK. If you don't want to think too much about that, just because there's no blade involved on that, you don't have a flap. So PRK is fine. Mitomycin get rid of some problems that we have in the past. That's the scar formation, that it's so-called haze and regression. But let's see what happened with this patient. In the third month, he was -0.5, -1, and the other eye -0.75, -0.75. This is very good. This was a fairly unexpected result. We know there's regression, so he had been overcorrected. So now he's myop, he was hyperop, and he will lose a little more of this hyperopia, this myopia that is very, very slow, very low, and he will become hemetrop or a little hyperop. So we were very happy at that stage. And then, and with this topography, so the right eye was more corrected than the left eye. You remember the right eye had more hyperopia than the left eye. And this is the differential map. You see how beautiful this is, where you can see this is the preoperative topography. Is the mouse here? Yeah. Preoperative topography. This is the post-op. You can see nothing from here to here, but if you go to this differential map, you see it's fairly asymmetric, like it was beforehand. Fairly asymmetric. It compensated, it corrected the whole asymmetry by using the wavefront guided treatment. Very good. And the other eye, perfect too. So everything is fine until the 11th month, when the patient came to us complaining about the right eye vision. And there was the cycloplegic refraction, plus 2.75, minus 375, and the other eye was fine. The other eye was plus 75, minus 1, something that we really wanted both eyes to be in. And then we saw the haze. So haze is something that we really thought had gone from our mind, from our eyes, from the patient's eyes. But we kind of see the haze coming back in some eyes, especially highly hyperopic or highly myopic treated eyes. And the haze was in that two positions. We'll see these. So it was in the temporal side and in the nasal side. And if we kind of locate it more schematically, you see haze in these areas, and the topography was flattened in the same areas. That's something also expected. When you have scars, the surface gets flatter and you will lose your effect. So this is the area where the haze was and overlapped to the topography. And here we see the same beautiful picture you had beforehand. That's the surgical change. We see the healing change, getting rid of the whole surgical change. So it regressed, not for the same, to the exactly same hyperopia he had before, but about the same. Third idea, the patient shall choose it, shall choose if he wants to have the surgical, the refractive procedure. And the doctor shall not indicate it if it's the case. They know the benefit and you know the risk. Okay? The patient doesn't know if it's risky or not. And you are not willing, it's not your decision to tell this will be good for the patient. That's his decision. He needs to tell you, well, you know what, doctor? I want refractive surgery. This will be good for me. This is the patient, this is the status of the patient we want to operate on. We don't want to operate someone that is happy with spectacles. They are already happy. It's very hard to get one from the happiness to the more happiness point. And this needs to be very, very clear in the patient's mind. My approach in the beginning is trying to take the refractive procedure out of the patient's mind in the beginning. So in the beginning, I fight with the patient. I said, why do you want to operate? Are you not happy with your glasses? You're not using contact lenses? Why? I can't understand. And then after the patient tries to convince you, it's really a balance. Then you said, okay, you convinced me, you have no contraindications for the procedure, your eye's fine, everything is fine. Now we are friends. Now I will not fight with you anymore. We will go through the whole process as best friends. I will be committed to you. But in the beginning, it's really important to have the patient willing to do the procedure. They know it's risky. No one is as full as someone tried to think, to sense that, in a sense that, well, I'm willing to do the procedure as long as you tell me the procedure is 100% safe. No, they know there's some risks, but they need to be willing to assume, to take these risks, at least in some part for their own. Topography. Topography really is the leading cause of technical, you see that I'm leaving the technical problems really aside. They are important, but they are not the most important part. So they are the leading cause of technical preventable problems, and we call it the hidden dragon. We see something in the topography. We don't see a lot in the topography, but this is an example where we have against the rule astigmatism, that in fact is probably a pellucid marginal degeneration. You see that it's starting to bend towards the inferior side, and it's probably a very bad case to operate this one. But we are starting to have doctors saying that any kind of against the rule astigmatism is bad for operate on. Maybe it will turns on to be keratoconus or a pellucid marginal degeneration case, and you don't want to be the one that start the process or that accelerated this process. So if you want to look at one exam to one device, that's topography, for sure. And in my mind, it will be topography for a long time. Having the Pentacam, the Galileo, the Orbscam, replacing the topography, something that probably we will end up having something as good as topography, but we already have something that is very reliable. We know for 20 years it's dependable on the reflectance of corneal surface, on the corneal epithelium and tear film, and this is very precise. So topography is important. Know yours and your laser limits in terms of refraction and corneal thickness. So this is the search for the perfect case. And here you see some diagrams where we try to define which is best, who are the best cases where the risk is very low. And in the green you see the minimum risk patients. In orange you see slight risk, gray they are moderate, and red maximum risk. And you see the change of indication from 99 to 2002, the expansion of the green area. So when we move from the broader beam lasers to small spot size lasers, we increase it pretty much that right-hand area where we have astigmatism with hyperopia, like the case I just showed to you. In the beginning, we really didn't want to treat that cases at all. Now we are willing to treat them. But know the limits. There's not such a thing as, oh, I'm going to treat, my laser, it's a very good laser. It treats up to -14. Any laser treats up to -14. You just hit there, he will tell what you want it to do. But in fact, physiologically, it's very hard to treat a lot. And the cornea will not accept. It will regress, most probably. So the limits are around 9, probably less than 9 degree of myopia, around 5 of astigmatism and hyperopia, and more than 5 and more than 9, it's something where you are in a risk situation. So if you want to search for the perfect case, the ideal patient, he'll be below 6 of myopia and below 3 of hyperopia. These are very good patients. These are really good patients. Let's try to aim for these patients in the beginning, and then we can move on. Why? Not because the technology will be better, but because our talk, our feeling, our relationship with non-so-happy patients will be much more confident. We will be much more self-confident in our results. So if the patient comes to us with -10, ±4, you will tell him all the risks they have. And we will just operate him if he is really aware of all the risks. Otherwise, you will not do it. But in the beginning, I would avoid this situation. Don't jump, but safely get on board on new equipment and techniques. And we call it incremental evolution, training, and coaching. These are my first 3 cases on femtosecond laser technology a year ago. So you saw in the first one the centration, very poor centration, very bad situation. Here you have a very good centration. There's a big meniscus and everything under control until poof. You had there a flap rupture. We call it anterior breakthrough. So that was a case with a scar. I already operated this lady, and I didn't know I couldn't do a femtosecond laser in an opaque cornea. There was the American lady who was coaching us in the beginning. She didn't tell me anything, and then I operated the girl, this lady, the flap just broke. Nothing really happened here, but I could not operate the patient. The patient was very close to me. I already know this patient for like 10 years, so she's confident. And nothing serious happened. But could. If I didn't know the patient was new, she came to me with the idea that, well, new technology is something that is pretty much closer to perfectness, to perfection. That never is, but in fact, if she came to me with this idea and that happened, I would be in a very bad situation also. So don't jump. Try to do this incremental evolution. I know this, so I want to keep this that I know and add a little bit more. That is safer. Teaching, training, as everything we do, And coaching. If you're not very comfortable, have someone doing that with you. But in my mind, trying to reach the independent level where you can do for your own. If something goes wrong, stop in the beginning. The importance of a preoperatory, comprehensive explanation. I already mentioned that to you. If the patient knows the things that can go wrong, he won't be very bad. It won't be very bad if something really happened, because the patient knew. If the patient doesn't know anything, then in the middle of the procedure, you will tell him, well, something went wrong, and the patient will go crazy, because he was not expecting that. He's expecting that everything went very smooth with no problem, and suddenly you said, well, you know, I couldn't apply the laser on your cornea. Why? Because the flap was not very good. Why? You didn't tell me. No, I didn't know that. And that's a very, very, very bad feeling. And you really can avoid that trying to raise the risky problems beforehand. So talk to the patient. Time share. Share time, not time share. In fact, both. Share time. Share your time with the patient. That both. Okay. In cataract, we usually tell, and you know that very well, when we are expirating that last piece of cortex, and someone in our side said, well, leave it there. It's better that than have a tear. In refractive, that's not that. In refractive, the best is not the good's enemy. Aim for perfection. So try to give the patient's best. They are expecting that. And we are already in a stage of development where we have the best. So I usually compare refractive with Formula One races, where you really need that 0.1 milliseconds to be in the first place. You cannot afford to lose half diopter of myopia. It will make the difference. So really try the best. Use the best laser. The worst laser is not as good as the old one. You have, and we need to value these differences and this perfectionism. Long-term follow-up is required. Sequential topographies, ectasia and regression only can be diagnosed by long-term follow-up and by sequential topographies. That's an interesting point where we start to be dependable on the technology that is already there and that has been there for a long time, and we really didn't care too much about that. That is the storage of the data. So we have our patient data on the device, on the topography machine itself, and we know it's there, but from time to time there comes someone or the company and it format the whole HD, the whole hard drive. And I said, okay, the machine is working, the same thing, nothing happened with the machine, it's even faster, good. And then here comes a patient who you told a year before that if something went wrong, or if something progresses, or if the topography was stable, you said anything about evolution, you would do this or that. And then the patient asks you, okay, what happened? And you said, I don't know, my HD was formatted, so I don't have your data anymore. And now we are very much dependable on data, on the preoperatory, on the previews, on the 10 years ago data from this patient. And we have devices that compare topographies all, along the time. We need them. We can really move if we have this data, if we have this information, and we will be paralyzed if we don't have this information. So let's see this case. Male wants to decrease dependency, the same story of spectacles and contact lenses that he doesn't use. Refraction, a small amount of myopia with some astigmatism. Cornea was good. The brother has keratoconus. Okay. And the topography was that. very hard to contraindicate this surgery. But I took this map from a guy that's a very friend of us, that's one of the most perfectionist guys that I ever met. I never wanted to be his partner because he wouldn't indicate a surgeon in anyone. For him, everybody is suspect. He doesn't have one topography that is really okay. He would say in this topography, well, but you see that area there, below there? Isn't it a little bigger than the superior one? It is, huh? And if you really look at it, isn't there a small place there where you can see the curvature that is, let me see if I can have it here. Here. Isn't it a little steeper than here? Okay, well, and the brother, doesn't the brother has keratoconus? Yes. Oh, we shall follow up this patient. Don't operate him, follow him. The other eye of the patient, little thing. And the brother, well, the brother was keratoconic eye. And so let's follow the patient. And from the beginning to the other topography 1 year after, and this is the difference, not much of a change, but you still have something here. So he was still intrigued by that. And then he waited more 3 years. And what happened? There comes the keratoconus. And here you see the change in the topography. And the other eye, same thing, the change in the topography. And the keratoconus developed in his face without surgery. Well, anyway, if he had surgery, it would have developed the same way. Yes, but then it was God's problem, not mine problem. Someone, the nature did it, not I did it. He would sue the nature, not me. And that's a real thing, even if we don't have lawsuits, and we don't have in Brazil too many lawsuits, but you have patients that are not happy. They may think, and they will say, that you did that to their eyes. Not now. Now you just didn't do anything. I just didn't operate you. And we are very seldom guilt about not doing things. Between LASIK, LASIK, iLASIK, PRK, TCAT, Z-LASIK, C10, all these letters prefer to know the corneal physiopathology. Deliver care to the patient, not to the market. Meaning that whatever you know best cornea, how the cornea behaves after a trauma, how the cornea heals, what the cornea performs if it's too thin. So we really need to know the basics. And this is pretty much okay to tell to doctors. We are used to do that. Until the undergraduate course, we want to know why. So when here comes something out from the sky, it's miracle, it will do things. The first thing we ask is, how? How does it do it? Explain me. If I cannot understand, I will not use it. So keep the track. The industry, and especially the representatives from the industry, they don't know the same thing we know. And they just know the final part. They will just tell us that, well, use my laser, use my blade, it will work. It's perfect, it's very good. Dr. X is using that, so it's very good. And they say, why it's very good? Why is it better than the other blade, the other laser? So really try to understand. Another patient, male, 32 years old, past history of HSV, herpes, without confirmation, but some history of that. No decrease in corneal sensitivity. Here comes the patient to the service, a university service, where we have a variety of backgrounds and of knowledge, and the patient with high myopia. Well, here we go, trying to do another PRK with mitomycin in -9. That's already a very high risk, and took out 142 microns of cornea. Why we did the PRK? Because there was not too much cornea to do the LASIK itself. Wouldn't be better to do nothing? Maybe, but there comes the surgery. And in the 7th day of post-operative, without contact lenses, that withdraw for itself in the second day and the patient did not return to clinic. There was that haze in the center of the cornea, low corneal sensitivity, low vision, without conjunctival injection, mild photophobia, in use of antibiotics and corticosteroids, and some non-steroid anti-inflammatory drugs, and some lubricants. Differential diagnosis, we don't know. Maybe herpes again, maybe some syndromes that have already been described associated with PRK or with LASIK, maybe this corneal melting associated with the non-steroid anti-inflammatory drugs as described with diclofenac, but that was not the case. It's too dense. Ours were much more infiltrated and kind of cloudy, like edema. Or maybe that other one related to fourth generation quinolones, but also this is very peripheral, much more epithelial. Ours was not like that, was in the very center. So nothing like that, maybe herpes. He had a history of that. And then we started a cyclovir, 800 milligrams a day systemically, even knowing that the acyclovir will just prevent recurrences. There's no paper published on use of acyclovir and shorter or better recovery of the eye itself. And some doxycycline, that's a tetracycline derivative. Very good for the ocular surface. Methylcellulose, fluorometholone, that's the corticosteroids with lower penetration. Antobromycin, lower dose, maybe something related to the toxicity of the drugs themselves. Here comes the patient worst. 10th day post-operative, he didn't come in the 8th or 9th day, so you already have a patient that is not attached to you. He was, like I said, in a university and a very high variety contest where ideal patients are fine, but problematic patients are very bad. Problematic patients are better if you have one-to-one relationship, one doctor and the patient itself. And there's the corneal ulcer with elevated borders. So that may really be a herpes ulcer trying to close, but not being able to do that. So the epithelium was with that slope. And someone at that point wanted to give him more medication, and we wanted want him to have less medication, thinking really that there was a toxic effect related to that. And so we diminished the medication, and he started to heal, and was better, and okay in the end of it. So there's a complication, okay, but you are supposed, as a refractive surgeon, to think about and to follow very closely this situation. So we need to keep being corneal specialists in order to be a better refractive surgeon. So I spoke about all these things here. And we may open for questions because I have more 10 of these pearls, and we can go on and on and on. But it's probably better to open for some questions, what do you think? Or for some discussion? May have enough. Okay. Yep. If you want to have some questions or some comments or want to talk about something that I didn't mention, something that I mentioned. Shall we?
When you use mitomycin?
When I use mitomycin. With patients with more than 3 diopters of myopia, I would say. We have some clouds in the sky or something telling us that if you are going to take more than 50 microns out of the cornea, it's good to use mitomycin. There's a there was a big fear about mitomycin because in the beginning they showed that when you use mitomycin, all the cells died. You don't have more keratocytes below the treatment. Well, what will happen with the cornea without keratocytes? It will fall apart. Will it collapse? Will it get thin? Will it disappear? What will happen? And in the end, nothing really happened. We have more than 10 years of mitomycin, and the patients are fine. So we nowadays are seeing doctors that use mitomycin for everyone. And what just varies is the concentration and the time they use the mitomycin. We are using mitomycin for more than 50 microns, 0.002% for 20 seconds. This is kind of preventable dose. And if the patient already have haze or a very likely condition to develop haze, like post-RK or a second procedure, we will use the same concentration, but for a minute. Knowing that is a source of worry, at least, because there already have been published some papers where a high concentration of mitomycin will damage the endothelium. If the cornea is thin and if you allow it to penetrate the cornea like through RK incisions. So it's good to have the patient knowing that. No, I don't know if to such an extent, like saying to every patient, well, you may have a corneal failure. I don't see a point on doing that, but at least to have the message to the patient, well, I'm going to use another substance in your eye that will try to modulate the healing process, but it has its own problems or risks.
Why explain the trend, as you mentioned previously, towards PRK against LASIK in the United States?
Why the trade?
Yes,
The trend.
Could you repeat the question, please?
Why the trend? Why are we doing more PRK than LASIK? I see some focuses and some explanations for that, and I would tell you the first one that come to my mind: economics, the cost of the blade. In Brazil, this is a very critical issue. In Brazil, we discussed it the whole week I was here, and I tried to convince Mirko that this is important in Brazil, not just the quality of service, but the price. We are in a very, very, very hard market. This is very wild. That there is very wild, so it's very sensitive to price. And if you, the doctor, can reduce your price for 70 euros, that's the average difference between one and the other one. That's nothing. They are willing to do that. So that's my first explanation. I think price. Second, here comes science. I think science already showed us that that's good. The mitomycin is fine. You can use it. Third, some science that are starting or trying to tell us that it induces less aberration because you don't have the flap itself. Third, little science that told us that the flap itself can have complications. And if we know a lot about cornea, we may have less complications. So I think there are some sides. But in the other part of the presentation, I will comment on LASIK itself. That's some procedure that has a very, very, very important wow effect. So it's a jewelry that we need to use a lot. It really brings more patients. It's not that much risky than the PRK itself. I already showed you 2 complications with PRK, none with LASIK. So I really think we need to use that. If we are willing to do PRK, and I have some slides on that, and I do a lot of PRK, we need to be prepared to give our mobile phone to the patient, answer the call, change the contact lenses in the middle of the night for the patient, do one eye at a time, do everything. And why am I willing to do that? Because I have a very peculiar relationship with my patients that I don't think is good or best or something like that. It's just the way I could survive in that market that is having a very, very, very deep, profound and bilateral relationship with the patient himself. I know the name of the mother, of the father. I already know him for 5 years. So, no, it's all written in computer because I saw the patient a lot of times. And having that, it's okay. It's really, they may call me in the middle of the night, not because of that, but because the children is with a flu and he wants the name of a pediatrician that I know. So they're mostly like friends. But I don't think we really need to do that for large volume clinics, not even for low volume where you want to have fast return of the patients. LASIK is much better. LASIK, in the next day you have a perfect, not a perfect, but almost perfect vision. The patients are fine, they don't have pain. They will tell to the other guy, oh, you know, I did a surgery yesterday. Oh, where? And they will be very happy. Incidentally, we had in Brazil a problem with that. It's so good that the patient started to tell, it is simple. This is a very big problem. You will not pay for things that are simple. We will pay for things that are complicated. So in the end, we lessen the value of the procedure because of that. But I'm sure you're not in this position, and I hope really you will never be in this position with this tough and unfair market.
Ok. Tem mais alguma coisa?
Tem mais, mas pode falar.
Não, acho que a gente vai. Okay.
Eu também.
So, I have one question just regarding that case in general. Discussion about LASIK and PRK, we can go on forever, and there are always good and bad things. Now, one thing for that particular patient is something that I will ask you. I put two hypothetical cases about when to do PRK, when to do LASIK, and when it doesn't really matter. But before that, just the patient that has a previous herpes virus. We know that one of the factors that actually reactivates. You don't have to come back. I mean, one of the factors that reactivates actually the virus is the UV light. And the laser that you're using is a laser that uses UV light. So what would you comment on? Is there any difference? Should it be done on the laser, or on the patient that has a herpes virus history? How would you prepare him? Would you do that you did 800 milligrams, or you would do 2 grams as a therapeutic doses? And the last, is there any difference to do PRK or LASIK in this case?
Several points of view. First, it is a relative contraindication for either LASIK or PRK. It is a contraindication for any type of preventable or elective procedure in the cornea. I wouldn't do cross-link on these patients. I mean, it is a relative contraindication. If I'm really willing to do it, and I had proofs that the patient had HSV, I would do preventable prophylactic doses of 800 for a long period beforehand, like for 2 to 3 months beforehand. It helps. Helps not having the patient developing the signs, the reactivation of the herpes itself. Regarding PRK or LASIK, there are two ways on looking at it. In fact, if you are doing the PRK, you will have the scar tissue all over again, and you need to use steroids. If you use steroids, you will decrease the immunologic status system of the patient, and it may regress, it may pierce much more than if you do the LASIK itself. So maybe the LASIK is much better for these cases. But if you do LASIK itself and you start to have melting of the flap, you are probably in a worse situation than you were here. The epithelium is very good on get rid of small bumps. Someone said that the epithelium has brains. It will see what you need and it will feel what it needs to be filled. So I would do LASIK, but I would try not to do procedures or cornea procedures in these cases.
So this is the message for because there are a lot of ophthalmologists that are not surgeons, but they cooperate with us. So herpes virus patient can be operated with the refractive surgery, but it's better not to if there are other solutions to solve it. Now the questions you raise are also the cross-linking, because it's not really elective procedure anymore. So in that case, I would slightly disagree with you. I would be more pushy, especially if the patient is young, because I know that it will get worse regardless of herpes virus. In that case, I think that we should treat him as soon as possible, and maybe we do with the dosage of 2 grams for a shorter period if something acute or topography is progressing quicker.
And even the corticosteroids treatment, no one really proved that it's necessary. So in the crosslink, there are some groups in the world not using steroids at all. And also the English group try not to use steroids in the PRK. And it seems that to be a safe procedure without steroids. So I
would like to use the fluoromethalone, but we don't have it on our market. It's not registered. So this, I think, would be best. Mm-hmm. Now, could you just go back to this slide that you put the topography compared to the place where you had the haze, the hyperopic, no, that one, the hyperopic astigmatism. So you had this nice picture. Where is the haze and where is the topography? Oh, there, perfect. Right. So this is now coming to fill up my side of the story. I like LASIK, and I absolutely agree that you have to share all the possible problems with your patient. I'm also a LASIK patient, so it helps me convincing my patient or sharing that risk with him. And I tell him when I did it 12 years ago, the risk was much higher than it is today. So I would never do a PRK in a patient of hyperopic or compound or mixed astigmatism, because simply the laser itself will shoot very close shot after shot. So it will probably have a thermal damage at that point. So the tissue will not be of the same quality, and that will actually call the myofibroblasts to make this uncontrolled haze, especially this one, which is late onset haze, which is always a headache because you never know where will happen. You live in, when I lived there, Brazil has a lot of UV light there. This is another problem. Here we go skiing, which is even more light, UV light than over there. So in this case, I would. How would you comment? Why wasn't LASIK being done in this case? Because it seemed like quite obvious indication of not doing PRK, like apart from being the protocol. Yeah,
the protocol.
Okay.
And this trend that in the university we are trying to avoid to get rid of the first explanation for that is financial, but to see, well, is it worth to do mitomycin in like every patient or not? And this is especially worse because in this case we couldn't conclude that, well, mitomycin fails. Why? Because in fact someone who did it used that small ring wheel to place the mitomycin on, and you know that the treatment is in the very periphery. So he didn't place mitomycin where the mitomycin needed to be. So you couldn't even conclude that. But I kind of agree with you. I think that if you want to avoid problems, a big flap there is the best choice.
Okay. Any other questions from the audience, especially the doctors that see my post-ops? Is there anything I should know? No.
Let me just do something here, because you really.
Something that shows that PRK is bad and LASIK is good, you can show.
Yes.
Okay.
Well, since Mirko will interrupt me, I really want to thank you very much